Hello, and thank you for joining CIVHC's Change Agent Chat. I am Pete Sheehan, CIVHC's Vice President of Business Development. Before we get started, there are just a few housekeeping items to mention. The phone lines are muted, and we will be using the Q&A feature to field questions and allow you to make comments on the discussion. Questions posed will be answered during the Q&A session. The webinar is being recorded and will be posted to the CIVHC website, so you may access this information again at any time without cost. Today, we've got the pleasure of speaking with Sarah Brown, a doctoral candidate from Brown University. Sarah's work evaluates policies that impact disadvantaged populations, with a particular focus on the effects of health insurance reform on access, quality, and disparities in healthcare. Sarah, would you care to say a few words about yourself?
Sure. So yes, my name is Sarah Gordon. I'm so excited to be here to talk about some of the work that I've been doing in partnership with CIVHC and using the Colorado All-Payer Claims database.
Wonderful. Well, thank you. We're very pleased to have you this morning or afternoon, depending on what part of the country you're in. Can you share a little bit about the inspiration for this project?
Sure. So the inspiration for this project is really that the benefits of any type of insurance, it can really only be realized if that coverage is continuous, accessible, and high quality. So this project really focuses on the first of those, the continuous piece. And in insurance in the US, there's a longstanding issue of churning, which has been well documented, which basically refers to moving in and out in between different types of health insurance. So this type of gap or transition in health insurance has been shown to have detrimental effects on the health of insurance beneficiaries because losing coverage temporarily limits your access to care. You can imagine that for someone who relies on prescription drugs or consistent mental health treatment, for example, a lapse in coverage can be hugely disruptive. Research has also shown that those with Medicaid coverage are more likely to be diagnosed with cancer later and are less likely to receive preventive services. Not to mention the fact that if one does seek care during a lapse in coverage, it can have negative effects on finances if they pay out of pocket for those costs, which is particularly relevant for the Medicaid population as their lower income. So on the system-wide cost side, it's also well documented. Churning is just inefficient. So the cost of one Medicaid beneficiary disenrolling and then re-enrolling is about 10 to 15% of average Medicaid expenditures for a healthy adult. So it's also been demonstrated that the longer Medicaid enrollees stay covered, their average monthly Medicaid expenditures actually decline. So it's really a cost-saving measure to keep those who are eligible for Medicaid enrolled continuously. And I think of it sort of as low-hanging policy fruit because it really comes down to an efficiency question, but one that also has profound effects on individual health, access to care, and administrative costs. So that's some of the general background that inspired this project, but then there were also a flurry of studies before the Affordable Care Act that predicted that the issue of churning was going to be a huge issue because the Affordable Care Act created different types of insurance coverage that were based on income, which means that if income fluctuated, people could move between those different types, creating coverage disruptions. So there haven't really been any studies to verify whether those predictions played out. And so this work was also an attempt to do that.
That's fantastic. And so it's great. It makes perfect sense. I mean, I guess I've switched insurances a number of times on the commercial side. And every time I do that, I've got to research, is my doctor in place? Am I able to go back in? So it makes perfect sense that we would see that on the public side too. Can you share a little bit more about some of the specific policies within the Affordable Care Act that you investigated as part of the project?
Absolutely. So I looked at two different insurance expansions that occurred as part of the Affordable Care Act, both on the private and public side. So the first was the creation of the individual marketplace, which in Colorado is Connect for Health Colorado. And so what I did in this was to examine the issue of people dropping out of marketplace coverage. So the way the marketplace is designed for the majority of Coloradans is that you pick a plan during open enrollment, it starts in January, and you stay in that plan throughout the rest of the calendar year. And there are lots of reasons that someone might decide to leave that coverage. One of them is if you got a job offer that has an offer of employer-sponsored coverage, you may leave, or you didn't like your insurance, or perhaps it was too expensive. So that was something that we were trying to get at in this study. And the issue is that when people drop out, they may become uninsured. But it also creates issues for insurance regulators and insurers who are trying to predict their overall costs and set prices based on who they project to be in their enrollee pool. So we found a couple very interesting things from this analysis of marketplace dropout in Colorado specifically. The first is that nearly 1 in 4 marketplace beneficiaries disenroll partway through the year. So that's pretty high, right? I mean, it's about 25%. And then we also identified some factors that were associated with lower rates of disenrollment. So, for example, those with incomes between 100 to 250% of the federal poverty level are eligible for cost sharing reductions, which help consumers pay for their out-of-pocket costs, so deductibles and co-payments and co-insurance. So people who receive that financial assistance actually have lower rates of disenrollment from the marketplace over time. So that is basically one potential factor that is leading folks to make the decision whether to stay or leave the marketplace in Colorado. We also found that young adults were by far the most likely to leave early compared to older adults, which again may be problematic because younger people are typically healthier. So it has implications for how we think about who's in the marketplace and what might lead people to leave it.
That makes sense. The young and healthy choose to do different things with their funds when the elderly portion may need to rely on that care and that insurance on a greater rate. This is really interesting information. Was there anything specific that you learned about either the marketplace or the Medicaid coverage specific to Colorado?
Yeah, so I also did a second project that focused more on the public side, on Medicaid. So as I touched on before, most evaluations of the Affordable Care Act expansions really focused on snapshots in time. So how many people gained coverage, how low the uninsurance rate was, et cetera. But health insurance is dynamic and time dependent. So with this project, we really wanted to see whether not only did expansions increase the absolute number of people who had coverage in Colorado, but was it giving them more continuous, uninterrupted, and long-lasting coverage? So in this study, we actually compared Colorado, which expanded its Medicaid program on January 1st, 2014, to its state neighbor, Utah. And so Utah in this study was a control state because it did not expand its Medicaid program. And so obviously these states are similar in some ways, not in all ways, but more similar than, say, Rhode Island and Colorado. So we compared them both because they both had all-payer claims databases, and we were able to look at some outcomes related to continuous coverage in Medicaid by comparing them. So this was a really interesting study because in Colorado, we found some pretty strong effects of the Medicaid expansion in the state. So following expansion, enrollees in Colorado gained an additional 3 months of coverage and were 19 percentage points less likely to experience a coverage disruption relative to their Medicaid counterparts in Utah. So it's important to note that these findings are actually among the subgroup of Medicaid enrollees who were in the program prior to expansion. So that's your pregnant women, parents, some low-income adults, and people with disabilities. But for these groups, we see that they are sustaining coverage for longer and with fewer interruptions after the implementation of the expansion there.
That's great to hear. I mean, great news for population in Colorado that there's less disruption in the services. Has there been any research done, whether it was part of your project or maybe with other projects, that attempts to quantify that from a dollar standpoint? Just thinking through kind of what the implications of that are, I would assume that that's going to result in some savings to the state.
Well, it's a really interesting question. I haven't done any work on it specifically, but I think there's sort of opposing factors, because covering more people always costs more money. That's just a fact of providing insurance. However, there are huge efficiency gains to be had in maintaining continuous coverage over time, both on the cost side and, of course, in terms of providing quality care that's continuous. So I think it would be very interesting to see, specifically among those groups who did receive more continuous care, whether there were efficiency gains on the cost side. And I think that actually is something that you could examine with the all-payer claims database because of the cost data that's included.
That's great, and that could definitely be something we look into. Good segue. Just would you be able to share your thoughts on just some of your experiences with the all-payer claims database? So you work with them in 2 different states, and just be curious to understand from your perspective what the benefits were to working with that type of data, and also, are there things that from an all-payer database perspective that we could be doing more of or do differently?
Sure. So I think there's huge promise for all-payer claims databases in general, especially for people, entities, researchers who are interested in state health policy, because particularly on the Medicaid and the marketplace, private individual market side, there's very little data that's available to researchers. And it's also typically quite lagged, so you can't get quite as recent years. And given that there's been such huge policy changes in the past 5-6 years since the Affordable Care Act, I think that is going to become a source that people are going to go to more and more in terms of research. The reason I was most interested in these data sets is that typically when we interact with claims, they are siloed by payer. So you can get Medicare claims, you can get commercial claims, maybe from one payer. It's very unusual to have them all in the same database, and to also be able to track people as they move through different types of health insurance and sites of care. So that's very, very important aspect of our health system. You know, in the US, we have different types of insurance for different people, but we have no idea how these different insurance types interact with each other and how people move through this system, quite fragmented system. So all-payer claims databases are essentially the only way to use administrative data to get at that question. And that was one of the reasons that I was most interested in examining this issue using that type of data. That said, I have come across a few limitations of the data that have made that aspect of it difficult. So, for example, there was a Supreme Court case that limited the participation, the mandated participation of self-insured employers, basically, so self-insured products. And so that's optional for those insurers to opt in to submit their claims. And so what that means is that if I'm trying to measure the number of people that are moving between the marketplace and employer-sponsored coverage, for example, I'm likely going to underestimate that value because of the lack of the self-insured claims. With that said, I can look at other transitions, which are still measures that have never been able to be looked at using administrative data before. So I think there are drawbacks, but it's still definitely a useful resource. And my hope is that the quality of the data sets and the inclusivity and comprehensiveness continue to improve over time.
Thank you for that. That's a great point. And I know at least here in Colorado, we continue to work with the self-insured plans that don't have to report in. We're working with them and on different ways to entice them to submit their data. So we've got a more robust picture, which is a great point. Are there any insights that you drew from the research in terms of how Utah and Colorado compare to the rest of the country?
Sure. Yeah. So I guess I'll start with the study that's on the marketplace side. So this is really the first study to estimate marketplace disenrollment and the peer-reviewed literature. So there's not a lot to compare it to, and I think that speaks to the uniqueness of the data. However, Colorado did experience a somewhat lower dropout rate than both the national average and some of the internal predictions that Connect for Health Colorado made when they were setting up and implementing the marketplace back in 2013. So the national disenrollment rate was about 28%, and in Colorado, they estimated disenrollment to be about 30%. So we're coming in with these estimates a bit lower than that at 24. So I think that that's a positive finding, even though it seems like a high number to begin with. And then in terms of the Medicaid side and what we found in reductions in churning, one of the co-authors who I'm working with on this study actually did a survey in Arkansas, Kentucky, and Texas, where he looked at the impact of Medicaid expansion on some of these continuity of care measures. And he actually did not find a difference before and after Medicaid expansion, nor between states that took different approaches to their Medicaid expansion. So in this work in Colorado, this is really a new finding that shows that Medicaid expansion appears to be an effective strategy to reduce churning in the Medicaid program, increase efficiency. And I think this has important implications for other states, namely Utah, which is voting on Medicaid expansion in November on the ballot. So it's a very exciting time to be working on these issues, I think in both states. And so, yeah.
That's great to hear. And I'm really pleased to know that the data, the research that's being done can help inform some of these really important policy decisions. With that, is there any questions that came in from the group on the phone?
Not yet, but feel free to type it in the Q&A box. So we have one here.
We have a question.
Are your research results published or going to be published?
Yes. The first study that I talked about in the marketplace is forthcoming in the journal Medical Care, so will be available. And the second paper is in the process of being published. So it's under review right now. And I'm actually working on a third project with the Colorado data that specifically looks at access to care among pregnant women in the postpartum period, because we hypothesize that continuity of care is particularly relevant for that population after expansion. So some forthcoming work.
That is a great point, and there's an organization that I've done some work with in the past called Nurse Family Partnership that works very closely, and I know they've got a program up and running in Utah and here in Colorado that attempts to help with some of that, the coverage and the work with moms right after they have their baby. So that's fantastic to hear. Are there any other policy recommendations that you might suggest to legislators or policymakers based on your decisions or on your findings?
Yeah, so I'll take the two sectors, public and private, separately. So in the marketplace, I think, so this was not a causal study, so it was associational, so my conclusions are somewhat limited, but it demonstrates that this financial assistance that's given to people to help pay for the costs of health insurance in the marketplace through premium assistance and cost sharing reductions with out-of-pocket costs, it's something that should stick around because it seems to be helping maintain the health of these markets and to keep people enrolled. So I think that this lends evidence to continuing to provide this financial assistance and that it's having meaningful effects to help consumers in the marketplace with costs, because we particularly saw the strongest effects among those who received the most generous subsidies. So for a group that is typically vulnerable to volatility in health insurance, this type of provision is really supporting them to maintain their access to care. So I think that's a big takeaway and something that has been somewhat in flux sort of with the national policy debate lately. And then on the Medicaid side, I think, you know, basically the idea of continuous enrollment policies. So for example, in Colorado, for kids who are in Medicaid and CHIP, the state has already mandated 12 months of continuous coverage. So that means that no matter what happens to you, no matter what your income fluctuations are, if you're a kid in Medicaid, you can maintain your coverage to the end of the year without having to redetermine and then potentially experiencing a lapse in coverage. And so something some states consider doing and some have adopted is extending that 12-month continuous eligibility to adults as well.
That's a really important point, and thank you for sharing that. I know that that extension of the coverage is really important to those who are having access issues, lost their coverage for whatever reason, and from a youth perspective, really important to the development of the kids as they move forward. Are there any other questions from the panel? Sarah, we want to thank you for your time. This has been great getting to learn a little bit more about your research, and we're so thankful that the data from the all-payer claims databases, both in Colorado and Utah, were helpful. We look forward to learning more as your research gets published, and we'll be staying in touch. Thank you so much for joining us today.
Thank you for having me.